Right. Okay. Good evening, guys, and very warm welcome. Right. So for those of you all who are new here, right, I'm Prashant, founder and lecturer here at the Med Commute, and so you're here with a special bonus session, right? So what we call Hospital Diaries, and of our Asclepius Lecture series. The goal here is, guys, for us to bring about professionals within the medical field from across various different regions, right? And what we want to do is to give you all a general idea of the differences in guidelines, treatment management protocols, right? How we approach patients, all the differences, right? So that wherever you all go with your medical career, right, you all won't feel lost and nothing is completely new to you. You all might even remember, right? We talked about this there, right? Joining us today, all the way from Michigan, United States, is our guest, Dr. Omesh Prathiraja. Right. So Omesh, just to give a brief introduction about Omesh, he was a graduate from Nanjing Medical University, batch 2015, and initially he worked in Ghana as an intern medical officer. After moving to the United States, he initially started off working at the Heart and Vascular Surgery Institute of Detroit, working with multiple professionals in the field. And he also worked in the infectious disease unit in Brooklyn. And in early 2024, he began his residency training at Michigan Bay Regional Hospital. That is where he's currently employed. So today, Omesh is here with us to share some of his valuable insights. Especially, we are focusing on cardiology, and the topic for today is heart failure. Now, just a few reminders, guys. This is a case-based discussion, so we would appreciate it if you all could keep your cameras turned on and interact with Dr. Omesh as he speaks, right? And if you all have any questions during the session, right, you all can send it in the chat box. And even towards the end, we will have a small Q&A portion. Right. So without further ado, let's welcome Dr. Omesh. Omesh, the stage is all yours.
Hello. Can you see me?
Yes, we can see and hear you, Omesh.
Okay, excellent. Let me just share my screen. Thanks, Prashant, for that warm introduction. So can you see my screen?
Yes.
Okay. Yep. So today I'm going to talk about an interesting case that I saw last week in the hospital. So hopefully we can discuss about the patient. This is an informal discussion, so please unmute at any time, or you can type in the chat box. And yeah, let's hopefully have some productive discussions. Let me open the chat box as well. Okay, so we have a patient who came to the emergency room last week, basically on the 4th of October at around 2:09 a.m. She's a 77-year-old female, and she was presenting with complaining of vomiting for 5 hours duration and shortness of breath. Here we have her vitals. So she looks hemodynamically stable. We can see her blood pressure is strong. She's oxygenating well. Her SpO2 is 97%. Pulse rate is 96. We went to take the history and physical exam. So in the history, her chief complaint was the nausea, vomiting. She did have some diarrhea and slight shortness of breath. For the history of present illness, her husband was there present at bedside. She said this vomiting started at around 8 p.m. She denies eating any new or different types of food. Her husband is asymptomatic. The only thing that was significant was she started using Ozempic 2 weeks ago and had an upset stomach and nausea for the last 2 weeks. But this vomiting and all of this started predominantly at 8 p.m. last night. When we do the review of systems, she denies fever, chest pain, sore throat, but she admits or endorses nausea and vomiting, abdominal pain, shortness of breath. Her past medical history or her medications are significant for diabetes. She's on insulin, metformin. She has hypertension on losartan, hyperlipidemia on atorvastatin. She has depression. She's on sertraline. Liver cirrhosis secondary to drug-induced liver injury. No history of coronary artery disease. Family history and social history are unremarkable. No significant drinking history, smoking history, IV drug use. There's no known drug allergies. So the next thing that we're going to do is go to the physical exam. So in the physical exam, she's alert and oriented ×3. So what we mean by this A and O times 3 is that she's alert and oriented to person, place, and time. So this is something that we always check when a patient comes into the emergency room, just in case they develop confusion later on. She looks slightly pale. Her oral mucosa was dry. Cardiovascular exam, it had regular rate and rhythm. S1 and S2 were audible. There was no murmurs, robs, or gallops. In the respiratory exam, you can hear diffuse crackles and decreased breath sounds. So that was something that was pertinent on our physical exam. On the abdominal exam, the abdomen was soft, non-tender, bowel sounds were present, and the extremities, there was no lower extremity edema. So the next thing is a differential diagnosis. So does anyone want to unmute or type in the chat box some differentials that they think this patient has? Yep. So someone's saying ischemic heart disease. So that's always important to keep on our differential. Sometimes patients can present, they don't always present with chest pain, they can present with shortness of breath or abdominal pain. So we should always have ischemic heart disease on our differential. Excellent. Cardiomyopathies. Okay. Yes. CHD. All right. So some other differentials that we have are acute pancreatitis. So this patient came in with vomiting and abdominal pain. So acute pancreatitis is always on our differential. She has diabetes on insulin. So we can also think of DKA or diabetic ketoacidosis. So people who don't take their insulin properly can develop diabetic ketoacidosis. Gastroenteritis, even though she's not having any fevers and didn't eat any new types of food, that's something that we should also keep on our differential. Acute coronary syndrome, congestive heart failure, because of the lung findings that we found on our physical exam. So we can think of congestive heart failure, chronic obstructive pulmonary disease, and pneumonia. So what would we like to order? Anyone want to unmute or type in the chat box some orders that they would like to place for this patient now after she came in? Yes, a full blood count. Good. Yep, fasting blood sugars. That's excellent. This is just an informal discussion, guys, so you can always unmute or, yeah, troponins. So if we're thinking acute coronary syndrome, then we want to check troponins to check if there's any myocardial infarctions. Yep. ECG. Chest X-ray. Excellent. Yes. So usually, basically all patients who come with any kind of positive lung findings will do a chest X-ray. Ketone bodies, excellent for DKA. So we'll especially check the beta hydroxybutyrate. That's the main ketone body that we check. Yeah. So CRP and LFTs, yes. So generally, so this patient was dehydrated. So the first thing that we gave the patient was IV fluids. So you can give 0.9% normal saline. And because of the vomiting, we gave her an antiemetic. So the one that we commonly use is, the trade name is called Zofran, but the generic name is ondansetron. So usually we'll give ondansetron or metoclopramide. Those are the two antiemetics that we usually give for any patient who is vomiting. So the complete blood count or full blood count, does anyone know what the full blood count entails? What does it tell us? Yes. Good. RBCs, WBCs, platelets, and oops. Another thing is, so usually when we write these in the hospital, we'll use this fishbone diagram. So when we use the fishbone diagram, we'll write the WBC count here, hemoglobin here, hematocrit here, and platelets. So this is just a common way that people usually write notes in the hospital. So it's good to get familiar with this. Yes, so the full blood count, it also gives us our MCV, MCHC. So sometimes some people might write the MCV on top of the hemoglobin, so we know what type of anemia it is. The next one is a CMP. So this is a comprehensive metabolic panel. Does anyone know the difference between a BMP, a basic metabolic panel, and a CMP? A basic metabolic panel is also known as the Chem7. Does anyone know what the basic metabolic panel entails? So generally, so this usually gives us our electrolytes. And this is usually drawn in this fishbone diagram. So we would write the sodium here, the potassium down here, chloride, bicarb. We'll have the BUN, creatinine, and then the glucose. So this is our Chem7 or our basic metabolic panel. Then when we go to the comprehensive metabolic panel, we're adding 7 more tests. So this one gives us our LFTs. So it'll give us our AST, ALT, our ALP. It'll give us our bilirubin, so our total bili. And it'll also give us our protein, so our total protein, the albumin, globulins. So this is what's also included in the comprehensive metabolic panel. So in this history, if you remember, this patient had cirrhosis and she's complaining of abdominal pain. So if we want to get the LFTs, we'll order a comprehensive metabolic panel. As you guys mentioned, ECG, chest X-ray, always lipase level if we're thinking acute pancreatitis, troponins, BNP. Does anyone know why we order a BNP or what a BNP is used for? Yes. So this is a marker that we use to assess for heart failure. So if we're thinking this patient might have congestive heart failure because of the diffuse crackles on her pulmonary exam, we'll order a BNP. Beta hydroxybutyrate. Does anyone know why we use that? Okay, so someone's asking a question, is BNP the same as ANP? So yes, it's not the same. These are actually two different things. So BNP was initially derived, they found it in pigs' brains. So it's called brain natriuretic peptide. ANP is atrial natriuretic peptide. They later found out that this is released in the brain, in the heart as well. But so they are basically the same thing. They're both natriuretic peptides. And what we mean by natriuresis is this is something that our body creates to help us diurese fluid. So that's what a natriuretic peptide is. So both these are peptides, so they both help the body diurese fluids. They're not exactly the same thing, but you can think of them as the same. Does that answer your question? Okay. Beta hydroxybutyrate. Does anyone know what we use that for? Yes. So that's a ketone body marker that we use for DKA. And then we'll also do a VBG. So a VBG means a venous blood gas. So sometimes we prefer this over an ABG initially. Yeah, that's a good question. So why not an ABG? Because an ABG, so it's very painful. So I'm not sure if any of you have had an ABG before, but sticking that needle into the radial artery, patients are in a lot of pain. And studies have shown that it's not as like it's the information we're getting, the extra information we're getting from the ABG is not so significant that it warrants doing an ABG over a VBG. So we can initially do the VBG. If we see something remarkable or we see something abnormal, then we can go on to an ABG afterwards. So we generally start off with a VBG and we can go on to an ABG. Does that make sense? Right. So the next thing, so now we've put our orders in. So next thing, we've got the chest X-ray. So here we got the chest X-ray image. Anyone want to unmute and try and read this chest X-ray or say what they see or give it a shot. Does anyone want to type in the chat box? They see anything abnormal or anything that's sticking out? This is not really consolidations. If it was consolidations, you would see so basically this whole area would be, you would see a solid opacity in the lung, something like that. Yes, yeah, there is some hilar lymphadenopathy. That's correct. Yes, enlarged heart. Yeah, so the enlarged heart, it could be due to left ventricular hypertrophy, but definitely there is an enlarged heart. So first thing, we can see that the exposure, the inspiration is good. So we can see enough, more than 6 ribs in the lung. There's adequate exposure. The main thing that you can see is this pulmonary vascular congestion. So like all these lung markings that you see is not, this is not, these are more pronounced. So this indicates pulmonary vascular congestion. You can see this hilar lymphadenopathy. You can see the increased heart. There's no bone fractures. There's you can see the costophrenic angles. So those are the main findings. And even if you're not sure what the findings are, you don't have to worry, because when you order a chest X-ray, it comes with the interpretation. So that's a good thing. So, but it's always good to be able to read your own chest X-rays, because sometimes it takes time for us to get these findings from the radiologist. So if you want to make a quick decision, it's better to be able to read your own chest X-rays. So here in the impression, the radiologist has written slight interval increase in heart size, central vascular congestion, interstitial markings, and mild vascular congestion. So the next thing we got is the EKG. Same thing. Does anyone want to give it a shot or see what they see? Or you can always type in the chat box as well. So this is just an informal discussion, guys. Yes, ST elevations, exactly. Perfect. So we can see ST elevations, especially in the anterior septal leads. So generally, when we look at the chest X-ray, we'll see if this is sinus. So we can see a P, QRS, T. So this is sinus rhythm. We'll check the rate. When we check the rate, you can count the boxes. So if you go here, this is 300, 150. So it's around 100 beats per minute. The next thing is we'll look at the axis. So when we're looking at the axis, you look at 1 and AVF. So you look at the R wave. So here we can see that this is pointing up. Here we can see that this is pointing down. So this indicates a left ventricular, this indicates a left axis deviation. You can see the QRS is not prolonged here. Over here, this you can see is in AVL. Another thing that someone wrote in the box was left ventricular hypertrophy. So usually there are some criteria that we use to measure left ventricular hypertrophy. So one of the easiest one is to look at AVL. So if this is greater than 2 boxes, or it's 10 millimeters, this is an indication for left ventricular hypertrophy. So this, yeah. And obviously the main thing is these ST segment changes. So, and also if you're still not familiar with ECGs, don't worry. Prashant is having a session tomorrow on reading ECGs. So that's something that you can join as well. So here we also have the computer interpretation. This is also saying, it tells you whether there's an MI or not. So here they're saying in the anterior septal leads, there's an acute MI. Sometimes I wouldn't trust this too much, but it's there. So now we have this patient. We saw the chest X-ray had increased pulmonary vascular congestions, and the ECG is concerning for MI. So next thing that happened is we got our labs back. So here, you can see in this diagram, so we have the CBC, or the full blood count on the left. We can see the WBC count is 9.9. Hemoglobin is 12.5. Platelets is 164. So these are all within the normal limit. MCV is 100, which is also normal. Next thing is, so we ordered the comprehensive metabolic panel. So as I said before, this is the sodium, potassium, chloride, bicarb, BUN, creatinine, and glucose. And another thing also is before we order imaging, just another point is we want to check the creatinine level before we give like contrast. So let's say if you want to give like a contrast enhanced CT or something, you want to make sure that they're not in kidney failure and that they can eliminate the contrast. So we should always check the creatinine level before we do any imaging with contrast. So I've put in red the things that are abnormal, so we can see the bicarb is kind of low. So this is probably indicating a metabolic acidosis. Looks like an anion and a high anion gap, because anion gap here is 21. The normal is around 10 or 12, 8 to 12. Next, so in the comprehensive metabolic panel, we got the total protein. AST is a little elevated, bilirubin's a little elevated. We have a coagulation panel here, which is all normal. Lipase is elevated, but this troponin is the main thing that sticks out to me. So the troponin is 939, and the BNP is also massively elevated at 15,000. Yes, so this is a high anion gap acidosis. Yeah, so and also in the VBG generally, so this is the pH, ECO2, bicarb, and the CO2, and the beta hydroxybutyrate is also elevated. So this is the labs, but the thing that should stick out to you and the first thing that you should address is this increase in troponins, and the patient has ST segment elevations in ECG. So afterwards, now this patient, when we went to check up on her again, she started complaining of some slight chest pain, around 5 out of 10 in severity. So this, with the EKG changes that we saw and the increased troponins, what's the next thing that we should do? Does anyone have any idea? Anyone want to unmute and say something or message? What would you do in this scenario now? So she's having some slight chest pain. EKGs show ST segment elevation. Troponins are elevated. Yeah. Dual antiplatelet therapy. That's reasonable. Yeah. So the first thing that we want to do, if we can do something, is call the interventional cardiologist, right? So the reason we do this is every hospital in America, they have something called door to balloon time, right? So if a patient is complaining of chest pain, has EKG changes and troponins, we should go and send them to the cath lab to see if there's any blockages in the coronary arteries within 120 minutes. So this is the standard guidelines in the country. So the door to balloon time is 120 minutes. If you can't do this, then you can give thrombolytics. But this is our goal. So if you have the facilities in the hospital, you should definitely do that. So the first thing that we'll do is call the interventional cardiologist, tell the interventional cardiologist about this chest pain, EKG changes, troponins, and go and do a left heart cath. Yes, 90 minutes. Yeah, I think so. One of them is 90 minutes, the thrombolytics, and then the door to balloon time is, I think, 120 minutes. So the next thing we should do is, now we're sending the patient to the cath lab. So I'm not sure if anyone of you have been to the cath lab, but this is generally what it looks like. Right. This is what it looks like. So here you can see, usually the interventional cardiologist is standing here. The patient's going to be lying down here. we'll usually put a catheter. Does anyone want to explain what a left heart cath is or angiogram? Anyone want to unmute and say something or something that they know? Yes, yeah, exactly. So it's a wire that goes into the coronary artery and releases the dye. Good. So we usually put the wire through the radial artery. It'll go up the subclavian and into the brachiocephalic trunk. And so this is what the cath lab looks like, and this is usually done when we have concerns of acute coronary syndrome. So the reason why we do a left heart cath, or this is also known as a coronary angiogram, is to check for blockages in the left coronary artery, the main coronary artery. So that includes the ascending um, left and left anterior descending artery, left circumflex arteries, and then the right coronary arteries. So we're checking for blockages. So you'll start off in the radial artery. You'll go all the way up. You'll go into the subclavian, then the brachiocephalic trunk. And over here, there's usually two openings, one on the left side, one on the right side. One person is how would you pick the radial artery over the femoral? So generally, they used to do it in the femoral usually. So there's two types of caths. There's the right heart cath and the left heart cath. Um, right heart cath is still generally done through the femoral. That's going through the femoral vein, and it'll go up to through the IVC into the right atrium, right ventricle, and check the pulmonary capillary wedge pressures. The reason why we don't do the femoral artery up to the heart is it's still done, but we would prefer the radial artery because there's less chance of infection. So an infection is a common complication whenever you're sticking a needle into the artery. We're worried about sepsis and all those kind of things, and especially like near the femoral artery, that's near the groin. It's not as clean, so we prefer the radial artery over the femoral artery. But the femoral is still commonly used when you're doing a right heart cath. So when we do this left heart cath or the coronary angiogram, so we're checking for this left coronary artery. So you check the left arteries here. You'll go to the right, check the right coronary arteries, the PDA, and you can also see the hemodynamics of the patient. So we can see the left ventricular pressures, the aortic pressures. So it gives us a lot of information. So what happened to this patient? So this is basically the coronary angiogram of the patient that we had. So here there's something interesting. Generally, the whole heart should be contracting at once, but over here you can see that the mid segments and the apical segments are not contracting, and it's mainly the base that's contracting. So I'm not sure if you can appreciate that. So this is a phenomenon that we call apical ballooning. So this is an unusual finding. Usually you want the whole heart to contract as one together. So obviously, we also get the report, and in the report, they'll give you the left ventricular ejection fraction. Does anyone know what the normal ejection fraction is? Do you think this is a high ejection fraction or a low ejection fraction? Or how do you calculate the ejection fraction? Does anyone want to talk about that? Or yeah, yeah, exactly. So this is very low. So usually what the ejection fraction is how much blood is being pumped out of the body, out of the left ventricle. So let's say if your left ventricle is filled, and let's say usually the normal left ventricle, we call this the end diastolic volume. That's around 120 cc's of fluid. Let's say each time you pump out, you're pumping around 80 cc's of fluid. So 80 over 120 that's around 66%. So this is what the normal ejection fraction is around in the 50s, 60s. So 15 is very low. Another thing to note here is so they'll go through the coronary arteries. the left anterior descending, left circumflex, right circumflex. You can see that these were free of any significant disease. So despite the troponins being elevated and her having chest pain and the EKG changes, there was no coronary stenosis or coronary blockages in the arteries. So next, what happened to this patient? So she started to develop acute hypoxic respiratory failure. The patient had increasing requirements of oxygen, and she required non-invasive positive pressure ventilation. So we gave that via BiPAP, and we sent her to the ICU. Does anyone know what the types of non-invasive positive pressure ventilation? What's the difference between that and intubation? Anyone want to unmute and... So basically, non-invasive positive pressure ventilation is any type of ventilation that we have where you use, no tube down the throat, exactly. So it's basically you're using a mask. So it includes like nasal cannula, high flow nasal cannula, CPAP, BiPAP. So these are all types of non-invasive positive pressure ventilation. Why we liked BiPAP, so why this is kind of significant is that, so BiPAP allows us to control the oxygenation and the ventilation, while these three only allow us to control the oxygenation. So BiPAP is more superior. This is usually what we use just before we would have a patient intubated. Next thing is we gave the patient IV Lasix or furosemide. So another thing that's interesting is you'll give this medication every 6 hours. So it's called Lasix. So the 6 means the half-life of the medication is only 6 hours. So Lasix, you make sure you give it every 6 hours. If you give it every 8 hours or every 12 hours, then the half-life is not going to last as long. We also gave albuterol nebulizers every 6 hours just to help with the breathing because the patient is having trouble breathing. We did a CT abdomen and pelvis, which was negative because we were thinking about acute pancreatitis before, and they did a bilateral lower extremity ultrasound. We're thinking maybe this could be a pulmonary embolism. That's also another thing that you should also always have on your differential for anyone who's presenting with shortness of breath, which was also negative. Then the next day, so we came back the next day, and then despite giving the IV Lasix, her urine output was low. So another thing is, so when we see a patient who has like a low ejection fraction, so this patient basically has a type of heart failure. So one thing that you'll see given in especially systolic heart failure in the acute setting is you'll give inotropic agents. So we started with milrinone. That's to try and help the heart, help basically the contractility of the heart and increase the blood pressure. On telemetry, we started to see multiple runs of non-sustained ventricular tachycardia. So we started the patient on amiodarone. And unfortunately, we had to change her from non-invasive positive pressure ventilation to intubation. So we had to put a tube down her throat because she couldn't sustain her airway. Next thing, so we did a transthoracic echo. And so the interesting thing was this patient did have a transthoracic echo done on the 1st of June as well, and it showed an ejection fraction of 64%. So there's a sudden drop from 64% to 15%. So that's very concerning. And another thing is, so when this patient came in, we usually write in our notes, what is her New York Heart Association classification when she's complaining of shortness of breath? And we had given her an NYHA score of 2. Does anyone know what the New York Heart Association classification is or what it's used for? How many stages are there? Anyone want to unmute and say something or type in the chat box? Yes, yeah, that's exactly right. So it's an assessment of heart function based on the ability to do physical activity. Yep, there are 4 types of New York Heart Association classifications. So this is something that we use commonly. This is what we use to classify heart failure. So here you can see that there's class 1 means you can just do all your physical activity. There's no breathlessness, you're fine. Class 2 means you have limited shortness of breath by doing physical activity. Class 3 means you're doing something that's less than ordinary physical activity and you're experiencing shortness of breath. And then class 4 means you're experiencing shortness of breath at rest. So even when you're not doing anything, you experience shortness of breath. So this is something that's useful and that you should know in the hospital, because we'll use it to classify patients with heart failure. So in this echo, you can also see this apical ballooning again. You can see that the basal segment is the one that's mainly contracting, and this mid and apical segment is hypokinetic. So we got the findings, and so this patient had ejection fraction of 15 to 20%, and the apical dilation and the hypokinesis suggests Takotsubo cardiomyopathy. So this is what this patient has. So that's what we're going to talk about today, and heart failure in general. So Takotsubo cardiomyopathy is a type of heart failure. It's especially a type of systolic heart failure, and it's also known as broken heart syndrome or stress-induced cardiomyopathy. So let's talk about heart failure in general. So heart failure, the main symptoms that you'd see is paroxysmal nocturnal dyspnea. Can anyone say what does that mean? What does paroxysmal nocturnal dyspnea mean? PND. Anyone want to unmute and say, or put it in the chat box? Yep, waking up with shortness of breath. Exactly. So paroxysmal nocturnal dyspnea. Paroxysmal means sudden onset, nocturnal at night, dyspnea, shortness of breath. So these patients will say that they're sleeping and they'll just wake up all of a sudden in the middle of the night, gasping for air. Orthopnea. Anyone know what orthopnea means? Or what? So orthopnea means you're having you can't lie flat. So these patients, they'll generally, when you're asking history, you'll ask, oh, how many pillows? They might say that, oh, recently I've been sleeping with 2 or 3 pillows, or I can't sleep on the bed anymore. They're not able to lie flat because of the pulmonary vascular congestion. So they have to sleep up on the chair, or they're basically upright. On physical exam, you'll hear crackles. Exertional dyspnea, you'll see a distended jugular vein, and dependent edema. So you'll see lower extremity edema. On chest x-rays, some classic findings are this bat wing appearance, which is the perihilar consolidation. You can see these curly B lines, which are the septal lines. All of these indicate basically pulmonary edema or increased pulmonary vascular congestion. And what's confusing about heart failure is there are 2 main types of heart failure. So you have systolic heart failure and you have diastolic heart failure. And another interesting thing is, so heart failure is the #1 reason of admissions in the US. So this is the #1 reason that people are coming to the hospital, getting admitted to the hospital in the United States. So it's a very important issue, and there is a high mortality rate. So it's definitely something that we should, keep an eye on and learn about. So there are 2 types of heart failure: systolic heart failure and diastolic heart failure. These both have different pathophysiologies. The heart is completely different, but they present in the same way. And also, so this is the left heart failure symptoms, and these are right heart failure symptoms. But when we talk about congestive heart failure, it's basically both left heart failure and right heart failure. So they have the same presentations. Systolic heart failure and diastolic heart failure present in the same way. The X-ray findings are the same. The tricky thing is the treatment for these 2 conditions are completely different. So here, one way that we categorize systolic heart failure and diastolic heart failure is looking at the ejection fractions. So if the ejection fraction is less than 40%, so this number's definitive, we'll call this systolic heart failure. And if the ejection fraction is more than 50%, we'll call it diastolic heart failure. So another term that we use is called HFrEF, or heart failure with reduced ejection fraction. And for diastolic heart failure, we'll call it HFpEF, heart failure with preserved ejection fraction. So basically what happens in systolic heart failure is that you have a very thin heart muscle. So it's basically floppy. It's like a plastic bag. So it's not contracting really well. That's why your ejection fraction is low, and your heart basically looks like this. This image is not moving, but it's basically showing like a weak heart like this. So in diastolic heart failure, what you have is a stiff heart. You have a filling defect. it can't fill with blood. But the ejection fraction is preserved because, so in the last example, we said if the end diastolic volume is 120, and each time you're pumping out blood, you're pumping out 80, your ejection fraction is 66%. But let's say now you have a stiff heart and you can only fill 60, right? And now you're pumping out 40 of that 60. Your ejection fraction is still 66%. So you're having a preserved ejection fraction. So this is a very important distinction, and I would remember the ejection fraction values as well. So less than 40% for systolic and more than 50% for diastolic. Does anyone have any questions? Okay. So next, we're going to talk about, so as I said before, the causes of these systolic heart failure and diastolic heart failure are completely different. So for systolic heart failure, the most common cause is ischemic cardiomyopathy, or they had some prior coronary artery disease. So this is the most common cause of systolic heart failure, and they have a prior MI. For diastolic heart failure, the exact cause is unknown, but we know that 50 to 60% of patients have hypertrophy. It's associated with age, diabetes, hypertension. So as people get older, they get diastolic heart failure. As people have uncontrolled hypertension, they'll get diastolic heart failure. Also, restrictive heart diseases can cause diastolic heart failure. So we said that this is a filling defect and the heart basically can't relax. So if the heart is infiltrated with like granulomas or iron, so in hemochromatosis, that can lead to diastolic heart failure, or amyloid in amyloidosis, or Fabry's disease, which is a lysosomal storage disease, post-radiation. All of these can basically not allow the heart to relax and cause diastolic heart failure. Another important sign that we see in diastolic heart failure is Kussmaul sign. Does anyone know what Kussmaul sign is, or would like to unmute and say, or type in the chat box? Yes, so the JVP increases on breathing. So this is something that we look for on physical exam. Generally on physical exam, yeah, JVP is excellent. So generally on physical exam, when someone, so this happens during inspiration. So on physical exam, usually let's say if you see someone's neck and we see the jugular vein, during inspiration, because of the increased venous return, the jugular vein disappears. And then when they're breathing out, it'll reappear. But on Kussmaul sign is basically the JVP is up, as like during inspiration, you can still see it, it's visible. And you have another phenomenon called equalization of pressures. So in diastolic heart failure, let's say if you do a Swan scans catheter, or you do a right heart catheterization, the right atrial pressure is going to be equal to the right ventricular pressure, which is going to be equal to the PCWP. So all of these, let's say this might be 20, the right ventricular pressure might be like 40/20, and the PCWP might be 20 as well. So you'll see, because the heart can't relax, the pressures are all equal throughout the right atrium, right ventricle, PCWP. So this is also another important finding. This is also seen in like cardiac tamponade and some constrictive pericarditis as well. But it's also a very important sign for diastolic heart failure. So as I said, the treatment for systolic heart failure and diastolic heart failure are completely different. So for systolic heart failure, we have something called the 4 pillars. This is called GDMT, which is guideline-directed medical therapy. So these are the 4 drugs that we use to treat systolic heart failure. So the first one is an ACE, ARB, or ANI. So an ANI is the brand name that we usually use here is called Entresto. It's basically, the drug name is sacubitril valsartan. So that's Entresto, lisinopril, losartan. So these drugs have been shown to improve mortality rates. They've been there's been lots of clinical trials, lots of studies, and they've been proven to increase the mortality rate. So patients with systolic heart failure, you want to get them on this GDMT therapy. You want to put them on the ACE, ARB, or ANI. You'll put them on a beta blocker. So only these 3 beta blockers are the ones that have shown a mortality benefit. So that's also a question that sometimes they ask. So carvedilol, bisoprolol, and metoprolol succinate. So usually there's 2 types of metoprolol. There's metoprolol tartrate and metoprolol succinate. So metoprolol succinate is the only one that has been shown to have a mortality benefit. We'll also want them on a mineralocorticoid receptor antagonist like spironolactone or eplerenone, and an SGLT2 inhibitor like dapagliflozin or empagliflozin or canagliflozin, some kind of gliflozin drug. Another question that they usually ask is we often use diuretics in heart failure management, but this has not shown any mortality benefit. It's just to help with the symptoms. So it just helps decrease the preload to the heart and improves the cardiac output. So another common question you might get on your exams is like, what drug does not have a mortality benefit? Yeah, so thiazide diuretics, they have not been shown to have a mortality benefit in treatment of systolic heart failure. That's a good question. So these are the only 4 drugs that are the guideline-directed medical therapy for treatment of systolic heart failure. A common question you might see in your board exams is like maybe which one does not have a mortality benefit? A, B, C, D, E. So the answer would be diuretics. So diuretics, it's used for the treatment of systolic heart failure, but there's no mortality benefit. So for diabetic heart failure, there is no guideline-directed medical therapy that has shown any mortality benefit. We usually treat the underlying disease. So let's say if the patient has hypertension, we want to control their blood pressures. Let's say if the patient has amyloidosis or hemochromatosis, we want to treat those underlying disorders. Just for your interest, there are some new studies which have shown that spironolactone has decreased the hospitalization, but there was no mortality benefit in diastolic heart failure. That was called the TopCat trial, and there was another trial called the Emperor Preserve trial in 2021. These are more recent trials, which are showing that spironolactone and SGLT2 inhibitors might have some benefit in diastolic heart failure, but the correct answer for your exams is still going to be treat the underlying disorder. Does anyone have any questions? Right. So just so another important thing is that the mortality benefit, even though systolic heart failure it might look worse, your ejection fraction is very low. Both of these have a 5-year mortality rate of 50%. So they're both high mortality rate conditions. So back to systolic heart failure. So as we said before, we said that ischemic cardiomyopathy, like having a prior MI or coronary artery disease, that's the most common cause of systolic heart failure. And then the other causes are non-ischemic, or it used to be called dilated cardiomyopathy. But we're not usually using the term dilated cardiomyopathy anymore. We just call it non-ischemic cardiomyopathy. Why we want to differentiate between ischemic and non-ischemic cardiomyopathy is that ischemic cardiomyopathies are associated with increased rates of arrhythmia, and these arrhythmias can be fatal. So generally what we do is if someone has ischemic cardiomyopathy, we'll put a device called an ICD, an implantable cardiodefibrillator. So if they have any kind of arrhythmias, they can get basically shocked back into normal rhythm. So an indication for getting an ICD is having systolic heart failure, ejection fraction less than 35%, with greater than 3 months of guideline-directed medical therapy. So that's also very important. And why we want to distinguish between ischemic cardiomyopathy and non-ischemic cardiomyopathy is that our threshold for giving these ICDs in ischemic cardiomyopathy are much lower. So right now we're going to talk about non-ischemic or dilated cardiomyopathies. So here we have a whole range of causes. So more than 50% are idiopathic. It can be due to viral infections. So after an upper respiratory tract infection with Coxsackie influenza. So for that, there's no specific treatment. Familial causes defects in cardiac cytoskeleton proteins. Peripartum, so late in pregnancy, sometimes they can have that. So interesting story is when I was doing my internship in Ghana, I had a patient in the OBGYN ward. After she had given birth, 2 to 3 weeks later, she came into the hospital. She was admitted for severe heart failure. This was her first pregnancy. So generally the treatment for that is to avoid future pregnancies, which that was not a good, people usually do not like that answer, but if it's it can be fatal, so we'll recommend avoiding future pregnancies. Chemotherapeutic agents can also cause this, like doxorubicin, daunorubicin. Tachycardia mediated is like in asymptomatic atrial fibrillation. This is a very common reversible cause of systolic heart failure. So if we can control their rate, we do rate control, or we can revert them back into normal sinus rhythm using a cardiac defibrillator, or cardioverting them back into normal sinus rhythm. This is one of the reversible causes of systolic heart failure. Other causes are HIV, alcoholics, and sarcoidosis, and Takotsubo cardiomyopathy, which is basically what we're here to talk about today. So Takotsubo cardiomyopathy, it's also known as stress-induced cardiomyopathy or broken heart syndrome. It occurs after severe physical stress, so sepsis, vomiting, stroke, or emotional stress. So let's say someone lost a loved one, loss of a job. One of my attending consultants told me that he saw a patient before. The patient lost her dog and then went into Takotsubo cardiomyopathy. So basically any kind of emotional distress or physical stress. So in this patient, it's most likely like she was vomiting, she had nausea, mainly that. So why it's called Takotsubo cardiomyopathy is in Japan. In Japan, there used to be this octopus trap called the Takotsubo trap, and we can see that this ventricle is kind of similar to how we saw our left ventricle. We can see the basal segments are contracting here, or it's more contracted, and the mid and apical segments are kind of dilated. Kind of looks like the apical ballooning. So that's why it's called. What is the mechanism of vomiting in Takotsubo? So that's a good question. Generally, it's not that vomiting can cause Takotsubo cardiomyopathy. It's some kind of severe physical stress. So this lady was 77 years old. She had a lot of nausea, vomiting for a prolonged period of time. And it was basically this event is what caused her. So actually, so this lady, she also went into sepsis when she was in the ICU. All of that is causing that. But the reason why sepsis causes it, the proposed mechanism is they think it has something to do with the catecholamine release from our body. So here we saw the markedly reduced ejection fraction. She had an ejection fraction of 15%. You saw the increased troponin levels, EKG changes, and we did the left heart cath, which showed coronary arteries were clean. There was no blockages. And the treatment is they usually recover in 4 to 6 weeks. So this is very important. Generally, once you treat the underlying cause, or if you just like, let's say there was a loss of a loved one, after time, the heart will go back into its normal size and have the normal function. So this is another picture. Here you can appreciate that these basal segments are contracting while these mid and apical segments are dilated. So it generally mimics STEMI, so ST segment elevation myocardial infarction, but there's no coronary artery occlusions, and it's more common in women. So this is the Takotsubo pot, what they used to in Japan to catch octopus. So this is an important finding that they usually mention, this apical ballooning of the ventricle. So this one, it was first talked about in Japan in the 1990s. So the prevalence is around 1 to 2%. So it's important that whenever you're thinking of acute coronary syndrome, you see the increased troponins, you see the ST segment changes in the EKG. The Takotsubo should be in the back of your mind because 1 to 2% of the time, they can present with these acute coronary syndrome-like features, but it's actually Takotsubo cardiomyopathy. There is an international registry, international world registry of Takotsubo patients, and 90% of those patients are women. So if you ever have a test question, it's basically going to 100% of the time be a woman who's in her between 55 and 80 years old. The pathophysiology is not well understood, but it has something to do with catecholamine release, microvascular dysfunction, and coronary artery vasospasms. The signs and symptoms are substernal chest pain, dyspnea, syncope, signs and symptoms of heart failure, like we saw. You'll also see tachy and bradyarrhythmias. So we saw that patient who had a tachyarrhythmia. She had multiple non-sustained runs of ventricular tachycardia. She was started on amiodarone. And they can also have cardiogenic shock. So you diagnose it with an ECG, biomarkers, BNP. Differential diagnoses you should keep in mind is acute coronary syndrome, obviously, cocaine related acute coronary syndrome, multiple vessel coronary artery vasospasms, myocarditis, and pheochromocytoma. So Mayo Clinic, they actually came up with the criteria to diagnose Takotsubo cardiomyopathy. So you need to have 4 out of 4 of these criteria. So the left ventricle, you need to see some wall motion abnormalities, which we had. You need to see no evidence of plaque rupture on angiography. So when you do the coronary angiogram or the left heart cath, there can't be any blockages. So this was ticked. New ECG abnormalities. So we saw the ST segment changes. We saw the troponins. So that's 3. And absence of myocarditis or pheochromocytoma, which we also saw. So she had 4 out of 4. So this is the criteria that we currently use, developed by Mayo Clinic. So I have some questions which basically summarize the high yield points that you should know about Takotsubo cardiomyopathy. So I'll give you guys a second to read this question. You can unmute and say the answer or just put it in the chat box. Yep, answers are coming in. Excellent. So this is a 65-year-old female. Came to the ED, sudden onset chest pain after an emotional argument, intense stress. Vitals are stable. ECG shows ST segment elevation. Cardiac enzymes are mildly elevated. The coronary angiogram shows no obstruction. And the echocardiogram demonstrates apical ballooning with normal basal contractility. So as most of you said, this is Takotsubo cardiomyopathy, obviously. And this is generally how the questions will come on your board exams. So the second question, which of the following findings on cardiac imaging is most characteristic of Takotsubo cardiomyopathy? Yes, exactly. Yeah. So this is also important. Apical ballooning with preserved or hypercontractile basal segments. So this is what we saw. The left ventricle was like this. So you have hypercontractile basal segments here, and you'll see the apical ballooning. So this is an important imaging finding that we see on echocardiograms. So that's something we should know. The last question. In the case of Takotsubo cardiomyopathy, which best describes the typical recovery and long-term management of the condition? Yeah, good. We see some answers. Excellent. So supportive care with most patients. So most patients will experience a full recovery of the ventricular function within weeks to months. So those 3 are the main things that we usually have. So what happened to our patient? So she's still in the ICU right now. She did go into sepsis. She recovered from the sepsis. She was on multiple presses. She's off the vasopressors right now. Telemetry has been good. It's not showing any new tachyarrhythmias. So we're going to most likely repeat the echo in another 2 to 4 weeks, and it'll most likely show a normal left ventricular ejection fraction closer to the 64% that she had in June. So that's it. Yeah, so someone's asking patients. Oh yes, patients' AGMA is due to sepsis. Yeah, and generally you can see another cause of anion gap metabolic acidosis is lactic acidosis. So probably if we got a lactate level on her, she would also be elevated. So a lot of patients who are just sick in the ICU, they would have a metabolic acidosis because of underlying lactic acidosis. But that's a good question. Anyone have any other questions?
Guys, we will open the Q&A session, right? Just 1 or 2 minutes. If you all have any questions, you all can ask Omesh.
Okay. Anxiety-induced angina. So anxiety-induced angina is different. This is more going into a type of acute coronary syndrome. So this one is more because of the vasospasms of the coronary arteries. So if we have the coronary arteries like this, when you have this anxiety or this thing, it can cause them to vasospasm and they'll clamp up. When they clamp up, you'll see increased ST segment elevations and increased troponins. So this is different because, I mean, both don't have blockages. So that's a similarity. They both don't have coronary artery blockages, but generally the demographic and the treatment is different. So usually people who have this, they'll need like calcium channel blockers, or the way we'll manage them is different to Takotsubo cardiomyopathy. And people who have this won't have the heart failure symptoms that we saw, the diffuse crackles on examination. They won't have the decreased breath sounds. All those heart failure symptoms won't be present in anxiety-induced angina. Does that answer your question?
Right. So if there aren't any other questions, let's wind up for today. So thank you very much, Omesh, for participating in the session and discussing this interesting case. Second, right. Omesh, is there an email that students can contact you with in case they want to ask any questions? Yeah. Can you just send it in the chat box? Yeah. Yeah. Right. Okay, guys. So there is one more question for you.
When did you discharge the patient? So the patient is still in the ICU. So because this patient was admitted last week, like on the 4th of October. So we haven't discharged the patient yet. I actually saw the patient yesterday. I'll probably go and see the patient today as well. Yeah. So she's still in the ICU. I just thought it was an interesting case to discuss with you guys, and hopefully there were some good learning points there.
Right. Okay, guys. So yes, Ayush, still a third year. Was difficult for me to grasp. Don't worry. Okay, we will learn everything. So a step-by-step process, right? Right. So don't worry about that. We'll have future sessions like this as well. So thank you very much, Omesh, for participating in the session, bringing us this interesting case. Hopefully we'll have you again someday in a future session, right? So that's about it, guys, from today's session. Just a small notice for the students joining tomorrow's session. We will be sending the skeletal note today, right? Just go through that. So that's about it. Okay. Hopefully catch you guys in a next session.
All right. Take care, everyone.